Okay, good afternoon, and thank you very much for my invitation for such meeting. And we'll discuss today the emergency in cataract surgery. Okay, in Mayo Clinic 2020, they mentioned some of ocular emergency. For example, orbitolitis, endophthalmitis, acute ankylosing glaucoma, optic neuritis, giant cell arthritis, central retinal artery occlusion, retinal detachment, and homonymous hemianopia, and they didn't mention anything about cataract. But in cataract, in reality, we can get emergency situation either pre-operative or intraoperative or post-operative. Pre-operative can discuss lens-induced glaucoma, either phacomorphic or phacolytic or phacoantigenic or lens particle following cataract surgery. Pre-operative also, in cases of primary angle closure glaucoma, they found that you can treat with laser peripheral iridectomy or subscleral trabeculectomy, but even they discussed if you will do clear lens extraction, this will control IOP. Preoperative lens subluxation and dislocation, and we can have many types of lens subluxation or dislocation. In case of subluxation, you can consider zonulisis, either one quadrant or two quadrant or three quadrant. In case of one quadrant, you have stable lens capsule, you can do phacoemulsification with capsular tension ring and IOL in the back. In cases of two or three quadrants, this will be unstable lens capsule, so you can shift to small incision cataract surgery and remove only the nucleus, and then you can use capsular tension ring and IOL in the back. If more than two quadrants, you can shift to ICC, intracapsular cataract extraction, and you can use scleral fixation or iris IOL fixation. Cases of traumatic cataract with open lens capsule can also, this will lead to lens cortical material in the anterior chamber with secondary glaucoma, and also small lens with shallow or lost anterior chamber. Microsclerophakia, and Professor Nahal Shakiri also discussed this in details, and also this an cataract emergency. In cases of intraoperative cataract surgery and emergency, we can have the posterior capsular rupture, and this we can get this signs for posterior capsular rupture, either sudden deepening of the anterior chamber, pupillary snap sign, increased red glow, decreased flowability, and nuclear tilt. In case of posterior capsular rupture, we can either we have just the nucleus or three quadrant or piece of the nucleus. If the completely dislocation of the nucleus, so this will have to do anterior vitrectomy and then sulcus implantation of IOL. In other cases, and just a fragment or a large part of the nucleus, you can convert to manual small incision cataract surgery or extracapsular technique, and then anterior vitrectomy and sulcus implantation. Intraoperative, we can face with suprachoroidal hemorrhage, and we will find thus lost red reflex, increased IOP, expulsion of ocular contents, and progressive shallowing of the anterior chamber. If you want to manage such case, intraoperative reforming anterior chamber and rapid wound closure, and don't do any extra maneuvers. Postoperative control IOP, control ocular inflammation, control pain, and perform B-scan. When to reoperate if there is no improvement or resistant high IOP, severe pain, or kissing choroidal detachment. Postoperative, you can got cataract emergency in case in shallow AC will have got leaky tunnel, malignant glaucoma, or suprachoroidal effusion. To manage either medical cycloplegic with topical antiglaucoma, intravenous mannitol, or surgical YAG hyalurotomy or posterior sclerotomy. Dislocated IOL after cataract surgery, you can dislocated bag IOL complex. We can use either fixation bag IOL complex with Hoffman technique or iris suture, or removal of the bag IOL complex completely. You can use iris glow IOL implantation or three-piece IOL implantation, either with clear fixation or Yaman technique. Cases of post-operative endophthalmitis. The golden standard is early, within hours after complication, 3-port Barcelona vitrectomy by vitrectomy surgeon. You can have the diagnosis, B-scan, urgent empirical intravitreal injection of antibiotics covering gram-positive, gram-negative, and anaerobe with vitreous and aquastab. Start medical regimen for endophthalmitis, including systemic and topical steroid, and repeat intravitreal or early vitrectomy. Endophthalmitis, indication of early vitrectomy if you have absence of red reflex and the poor presentation of the vision on endophthalmitis, so have to operate early. This was in short how to be cataract surgery to be an emergency. Thank you for listening.
Thank you very much, Professor Dr. Ahmed, for your very brief summarized ocular emergencies in cataract